Welcome to Inside the Doctor Studio Retina. I'm your host, Arshad Kanani from CRI Associates in Reno, Nevada. This is the second episode talking about diabetic retinopathy, and I'm here with my guest, Dr. Rishi Singh. Hi, Rishi.
Hi, Arshad.
Tell us about yourself. Let's get started.
Yeah, it's a pleasure to be here, Arshad. So I've been a staff surgeon in the Cleveland Clinic now for the past 15 years. I can't believe it's 15 years. It's gone by so quickly. I just got a plaque in my office for my 15th year anniversary. Before that, I was up in Boston. I did my residency training at the Mass Eye and Ear Infirmary, and I actually grew up in New England area. So this was a transition out to the Midwest, but I've loved it so far and continued being out here for the past couple of years and hope to be here for many, many years to come.
That's great, Rishi. And how did you get interested in ophthalmology and especially retina?
You know, ophthalmology is one of those things where I think I really like the microsurgical environment of ophthalmology. And that's why I looked at a lot of other fields with similar sort of areas. Plastic surgery, even obstetrics actually has portions of it. Gynecology has portions of it that are microsurgical in nature. It became a very different field in the past couple of years. So I was looking at all those sort of microsurgical opportunities. And it happened to be that I was in a work study program. And as you know, those work study programs, you have an option of choosing these really mundane jobs. You know, you could work in the cafeteria and get a work study grant, or you could work in the library and get a work study grant. But one of the ones that I chose happened to be washing dishes in a lab. And the lab happened to be a corneal research lab at Boston University. And so as an undergraduate, I used to go over to BU undergrad camp, the BU medical campus, and actually do research there and wash dishes as my first starting job. And then that blossomed into doing Western blots, Northern blots, and then learning more about PCR, and then having more of a basic science experience with the principal investigator there. And she was very influential in my life, actually. I've thanked her since I've had a chance to see her at Arvo for many years in a row. But she was the one person, I think, who really took a lot of my work and challenged me with the work. Thought I could do better. Really pushed me to do more research activities, ask more questions, to refine the way I write and I present things. She was just an amazing tour de force for me. And so I credit her with a lot of my success in life because she was the person who really pushed me to get to a different level.
That's a great story, Rishi. And I personally, I worked in the lab too. I fed liver to frogs, and I also washed the dishes. And it was an electrophysiology lab that I worked in.
Right.
Nothing to do with eyes, but I found out I'm not made up for basic science research. That's what I found out doing a couple of summers there. And it's so interesting that we all have different experiences that drive us. And so tell us about, why did you pick Cleveland Clinic, and why academics, and why not private practice?
Yeah, so it was a tough decision. You know, Cleveland was chosen because it was my fellowship location, and I didn't have a choice really over that. It was through the match process. But when I got to Cleveland, I happened to step into the opportunity where I realized just how much you could do here. Cleveland Clinic tends to be one of those organizations that is not like the typical academic, ivory tower organizations where you have all this red tape and you can't do stuff and you can't, in order to get something done, it takes you 6 years and 6 processes to get done. You know, it's not like that here. And I happened to walk into a service where there were only 2 or 3 other retina doctors here at the time. The chair, and then Peter Kaiser and Jonathan Sears. And so it was a real opportunity to do clinical studies, which they hadn't done a lot of at the time. They were doing a few here and a few there, but not many patients, not many studies. And Peter obviously is sort of a good mentor of mine because he's done so much to contribute to the field of ophthalmology. And so I looked at that as really being a big advantage. I did look at other jobs. I did look at private practices, even in my own city. I think it's just the difference of what I want to do academically. I always feel like my driving force, my mantra has always been to make a contribution to ophthalmology or make a contribution to science in some way, to patients. And so I felt like I could make a bigger contribution by being here versus being in those locations at the time. So.
No, that sounds great, Rishi. And I think the satisfaction you get by teaching residents and fellows, and then they go out there and do great things, I think it's a very, very good feeling to kind of help people on a mass basis by training star doctors and fellows that you do.
Yeah, no, I mean, I think it's dawned on me even as much as last night. You know, with this COVID-19 pandemic, I've had a lot of other family issues which have plagued me for the past couple of months, and it's been a long slog for the past couple of months between the family issues and the COVID issues, obviously. And last night, on sort of beyond my control, a lot of my fellows want to do a Cheers to Rishi Zoom party, and so they had the Cheers to Rishi Zoom party, and they invited, you know, probably good 7-8 years of fellows, Dilsher and Nathan Steinley, and a lot of my more recent fellows, Yasha Modi and Adi Smith, and these people that have just done great things and are contributing in many different ways to ophthalmology and to retina, and even people in my partners in industry I've worked with in the past couple of years. So it really just tells you, I mean, it's like one of those It's a Wonderful Life experiences where you realize how many lives you affect by doing what you're doing. And similar to what you probably do with your fellows and your practice, I mean, after years and years of doing this, I feel like I've had that reflection recently. So it's been great.
Yeah, no, I think your colleagues become your family and your patients become your family because you are seeing them so often, and then your staff becomes your family because you're there with them so many hours each day. So Rishi, let's move on and talk about your clinic. How many
Yeah.
patients do you see on a regular day? And you mentioned COVID-19. How has changed your practice at the Cleveland Clinic?
Yeah.
And we're gonna later talk about diabetic retinopathy and diabetic eye disease.
Sure. So I'm a hybrid sort of practice environment where I see a high volume number of patients for 2 days a week. So I see between 60 and 70 patients on 2 days a week, and then do 1 day of surgery. And the remaining 2 days are spent doing administrative/research activities, which are supported. I'm on the board of the hospital for the Cleveland Clinic, so I have those responsibilities as well. So that was it's a pretty busy practice, obviously, just like yours probably. And that changed a lot when COVID-19 came around. I think the retina volume certainly took a hit. I would say it's not 100% hit. It was more like a 50% or 40% hit, where we saw far fewer patients. Many patients deferred their examinations, obviously, and didn't want to come in. And I think that has slowly returned. I think we're at a volume now. We're probably close to 90 to 95% of total capacity. I just looked at my schedule for Monday, and I have close to my normal volumes for Monday and Tuesday next week. And so I think it's returned, albeit I think I feel like I'm doing more work than ever. The toil of seeing a patient now, like you said, like, you know, they consider them part of your family. I mean, you go and you touch them, you hug them, you give them a handshake,
Yes.
you high five them, do whatever, and then you leave the room, and it's a very quick turnaround time. Now with the controls around making sure we wipe every room down properly, sterilize the room for a certain period of time, you know, obviously socially distance the patients, so your schedule becomes ever more expanded. You're trying to COVID test all the patients for more surgery. So now that is another additional piece you have to worry about. So things are I think, back to normal, but it's a new normal. It's something that we're going to have to get used to. And it's honestly very tiresome, because I think that the amount of work effort has gone up a lot as a result of doing all these things to keep people safe.
No, I agree. I think you have to take a lot of time in between patients. I think the efficiency has gone down. Tell me about your diabetic retinopathy patients and how you treat them, just diabetic retinopathy without macular edema, and also if pandemic has changed that. You know, I'm not seeing many of my diabetic patients, and I'm not seeing as many new referrals. Don't know if because the buffets are closed at the casinos here. I don't know the answer, but it seems to me that I'm seeing a lot of advanced diabetic retinopathy patient, not early like I used to. So I don't know if pandemic has changed that or not, but tell us about your diabetic retinopathy patients and how
Yeah.
are you managing them, and how has the pandemic changed their visit schedule and your approach to treatment?
Yeah, so the DR patients, I was sort of an outlier in my practice because I was the person who's treating them with anti-VEGF. Many of my colleagues still, with Protocol S and other studies that come out, weren't so buying into the idea that anti-VEGF therapy was sufficient for proliferative diabetes. I had bought in because I had some really great case examples, which really just did a great job. I could send them 3, 4, 5 months of time between anti-VEGF treatments, and they did wonderfully. I think with the change in the COVID-19 pandemic, I'm seeing diabetics who are coming in who are far worse than I imagined them to be.
Exactly.
Yeah, they're coming in with tractional detachments, vitreous hemorrhages. I see too many now bilateral, legally blind patients who come in on presentation, where you're essentially scheduling one eye for vitrectomy and the other one for anti-VEGF and PRP the following day. So, it definitely took a toll, I think, on the patients who are diabetic. And I think overall, the patients are definitely going to suffer as a result of this situation. I think omitting their visits for a lot of reasons, because their own health considerations, and also because there was some mandates to decrease our clinic volumes, is going to lead to obviously some issues with regards to that with our patients. So we're going to have to see what the consequences are of that as time goes on. So far, I think there has been, in my estimation, patients who've come in much more sicker than ever before.
No, I think my experience is the same, Rishi. So you said you're treating patients with PDR with anti-VEGFs. What about patient with moderate or severe NPDR? What are you doing now with them? You saw the recent data from the PANORAMA trial, I think, the 2-year data, and then we know the data from RISE and RIDE that led to the approval of ranibizumab, and PANORAMA got the aflibercept approval. So are you treating moderate or severe NPDR patient with anti-VEGF, one? And if you are treating them, what is your protocol?
Yeah, so for severe NPDR, I definitely offer the treatment. I talk about it with a patient. I make a decision with them. I discuss the pros and cons and have them determine if they think that they're eligible, they want to consider a treatment for that. I'd say 50% of them agree that it is worth treating them. And they realize that, first of all, the aflibercept is a durable option with a very, very good high efficacy bar, especially with these patients, especially given the PANORAMA data study. And I look at it like we're trying to prevent vision-threatening retinopathy complications more than anything else in these situations. And just thinking about that, that's the way I phrase it with patients. Just thinking about it like, if you had a vitreous hemorrhage tomorrow, could you function with one eye for 3 to 4 to 5 weeks until the hemorrhage cleared? Or would you really be stuck? And if your answer is yes, then starting out with anti-VEGF therapy in the severe NPDR category, where you're going to progress and you have a high bar of improvement, is a good way of starting off and doing that sort of thing. I think too many patients decide to kick the can down the road and decide later. And if it was my eye, I would say to you, if I was a diabetic and I had mild, moderate, or even proliferative, severe proliferative disease, I'd say start with anti-VEGF with me now, rather than going through vision-threatening retinopathy complications later. In proliferative disease, it's a hard buy to determine how to handle that right now. I think still with the data, I think it's a little controversial. But yet I still do use anti-VEGF in those patients, maybe also PRP, depending on the situation.
So what about patients who decide to do, let's say, aflibercept based on the PANORAMA data, and they have severe NPDR? What is your treatment protocol? Do you give them loading doses? Do you do one? How often do you do wide field FAs? How do you monitor those patients? I think those are the great questions that we'll like to hear from you about your opinion.
Yeah, so I think the most recent study I saw that I think was probably the most impactful for me was that they found that the number of hemorrhages improved, but the amount of venous beating did not improve in some study recently. And it gives you a sense of what's happening in these patients. Essentially what you're doing is mopping up some of the hemorrhages, making things look prettier. Yes, you are improving their retinopathy severity scoring, but the underlying disease state is still there. And so what I tend to do is I tend to decide on titrating the patients based upon their presentation by giving them one injection and then following them the next month and giving another injection, and then eventually extending their intervals out when I see the retinopathy severity score sort of stabilize. So if I see there, for example, after 3 injections that they've gotten 1 or 1.5 or 2-step improvement maybe on photos, just comparing the photos and looking at them together, then I will start to extend the patient out. And if they have any sort of VTR complications or any other sort of worsening of the retinopathy scoring, then I'll tighten the interval again. But frankly speaking, I think most patients can go out 2, 3, even 4 months between injections with aflibercept in this paradigm and still do really, really well and not have VTR complications, which I think is the biggest thing we're all trying to really prevent here, amongst many other things, is keeping them working, seeing productive individuals, especially during this time.
No, I think those are great points. I think based on PANORAMA, there's a possibility to go 16 weeks, and I think I do the same. If I have a patient that decides to get anti-VEGF for DR, I think every patient is different. And I think the goal is that we stabilize and maintain their retinopathy. And, people talk about regressing the disease, which as you said on pictures, you see the hemorrhages go away, but if you stop treatment, then it will get worse. So I think you have to have the right patient, and each patient's needs are different. So let's move on and let's talk about what is the best thing you can hear a diabetic patient say to you, and what is your least favorite thing to hear from them?
The best thing I love to hear from them is just the satisfaction they're getting with the treatment they're having. So it could be a patient who underwent successful tractional detachment surgery. It could be a patient who had underwent successful anti-VEGF treatment for DME. It could be a patient who just had a nice improvement in their hemorrhages from a vitreous hemorrhage, for example, from anti-VEGF therapy. So that's the best thing I think I love hearing about. The worst thing is them saying to me, the injection hurts so badly that I'm never coming back again. And the problem is we have just these, again, it's not a one size fits all for anesthesia, but we do the best we can with it. But then that's a kiss of death for me. I almost think that patient's a laser patient at that point. And I've had some patients like that. They've just sort of said, I tried the injection, didn't work for me. Or I tried office-based laser, didn't work for me. And then I'm like stuck because I have to decide if I'm going to take this patient to the OR and do it there and put them under anesthesia. And sometimes I've done that, but honestly, it's a lot of work to do that. And I think that most of them could just, unfortunately, for lack of a better term, grin and bear it for those cases, but they're not willing to tolerate it. And that's hard.
No, I think, what I see, I usually use subconj for my injection. So when I go to laser, they don't want to have the laser because they're like, I'd rather go back to injection after you put like 5 or 10 spots of PRP.
Yeah.
What anesthesia do you guys use? And I'm sure your first year resident doing the injection, maybe that's the reason it hurts.
No, the first year
Just
resident
kidding.
doesn't even know where to inject per se. So that's not a case for us. It's usually a fellow or myself. I tend to do 50% or more of my injections in my clinics because I just want to participate in the process of caring for the patient. So we do subconj for the intravitreals, but for lasers, I do peribulbars a lot of times because I
Oh,
just
you
want to
do?
make
Okay.
sure that they're very, very comfortable. I mean, I hate to have a patient in pain. That's not what I want to do. So peribulbars are easy, quick. They don't hurt very much if you do them right, and they can lead to a good amount of anesthesia if you really put it in the right spot, and that can be very beneficial to the patient for a PRP procedure.
No, I think that's a really good advice. I think peribulbar is easy, and really, if you don't do it, patients do hurt,
Yeah.
obviously, during the laser. So Rishi, before we move on, tell me, what are you most excited about from upcoming treatments or delivery system for management of diabetic patients, and what do you think is going to be the biggest game changer in our space dealing with these patients with diabetes?
I think expansion to other MOAs is always interesting to me. I mean, it's so hard to believe that we've treated patients with anti-VEGF therapy now for over 15 years now, and it's always been VEGF-A inhibition. I mean, just like it doesn't inherently make sense that one disease can have one drug that's that impressively powerful, and it may be that case, but I just find it hard to believe. I mean, there's so many other disease states we take care of in oncology where you find multimodal therapies better, and we haven't in our conditions, in our treatments, incorporated steroids with a regular basis in these conditions too. So I think that multimodal therapy is something that I'm excited about, whether it be Ang2 inhibition, whether it be pan-VEGF inhibition, whether it be some other sort of case. Clearly, the high dosing of drugs is going to have to be tested. I think that's an important way of testing it. I know Regeneron is involved in a high dose study right now, which I think is good and important to do. I'm just not clear, of the real benefits of it because no high dose studies really worked out that way.
Right.
And then the last is the delivery systems. Obviously, there's some delivery systems nearer rather than farther, and those are super interesting too. Albeit, I'll say that they're probably going to be reserved for some very specific patients because surgery is surgery and it is complicated and it has issues with it. And a diabetic imagine taking all your diabetics to surgery. I'm not sure that's the right bar to be hitting, especially in that population of people that is working age adults and needs their vision right away. And you don't want to give them a complication, especially when surgery happens. So it'll be interesting to see how that fares with people like this, especially.
No, I agree. I think overall very exciting times with different MOA, as you said, and sustained delivery, whether it's port delivery or gene therapy and other modalities. So Rishi, tell us about if you were not an ophthalmologist or a retina specialist, what profession you would have chosen, or would you like to have attempted, and what would you'll be good at, and what you'll be horrible at?
No. I think I've always toyed with the idea of being a mechanic or being in sort of that, working with my hands a lot. I think that's a kind of a rewarding field of working with your hands and making something happen. I've toyed around with it a little bit, not too much to my liking to make something happen because I'm too afraid of hurting myself. And I'm sorry, what was your next question?
Next question is, what profession would be horrible at?
Oh, guitar playing. I know I'll be very horrible at. I've tried that before.
Yeah, me too.
I took,
It's too hard for me.
I took lessons for 2 years, and my fingers hurt every time I played, and I never practiced enough. And I thought this is gonna be so easy. I mean, how can total morons are in rock bands? So I could totally do this. But no, it didn't work out that way for me. I really hurt my fingers playing, and I realized I needed my fingers from a day-to-day basis. I just was like done with it. So.
No, that's great. And what about travel? When the world opens up again, what will be the first place you're gonna go? Is
Yeah.
it gonna be Hawaii or is it gonna be somewhere else?
We had a trip planned to Machu Picchu before this whole thing, in Peru before this whole thing, because Peru is a large culinary capital of the world, and Machu Picchu obviously is one of the very rare wonders of the world, which may not exist in a few years to see. So my family and I had planned on that trip back in March, and we were initially very encouraged to go because the COVID numbers are so low, albeit I think it's because of under testing right now is what happened. Because they're like the rip-roaring poster child for COVID-19 in South America right now. So I hope that works out and we end up doing that in the future. But that would be my first trip, hopefully, if we get out of here.
And what about your favorite retina-related word? This is a question I ask everybody on this show.
Oh, pseudodrusen. That's my favorite.
Pseudodrusen. That's pretty good. I like it.
I always think that they're the most interesting things, and finding them and then what they're like, and then you have to classify them as reticular pseudodrusen or the traditional pseudodrusen, and they have different implications. And I always find myself at a quandary having to look up again what they look like, whether it's reticular or regular pseudodrusen. So I think that's probably one of my favorite words to talk about.
No, that's great, Rishi. And then last question, everybody gets answered. So when you retire and you already have a successful career, Rishi, you've been doing it for 15 years. You won the investigator award from ASRS a couple of years ago. You have published hundreds of papers. You have trained a lot of fellows who care for you. So tell us how you want to be remembered and by your patients as well as your colleagues.
I think ultimately I want people to think that I made a difference in their lives and contributed to science in general. I don't know what it is. I've always wanted to make some sort of contribution. And it doesn't have to be tied to any monetary value for me. It's always been something I've done even despite the monetary limitations. And I hope they remember me for that alone. I think that that's been my driving principle all along. And I sort of have this mantra that I always say to myself. I always say it's more than zero. So more than zero means you attempted to do something that you probably wouldn't have done. So it's more than zero. You actually gave yourself the chance to try something or to do something, more than zero. Or you contributed to something that you thought that you had no role in contributing at all. Like you were way out in space and this is not your field or your area. So it's more than zero again. So those have been my two driving principles recently that I think have worked well for me.
Thanks, Rishi. That was great. With more than zero, we're gonna go ahead and close our show. It's so nice to have you here on Inside the Doctor Studio, and we appreciate you taking the time to be here.
Thanks, Arshad, for the interview.
Thank you. I am honored to have my second guest here, David Eichenbaum from Florida. Hi, David.
Hi, Arshad. How are you?
Doing good, David. Tell us about yourself.
So, first of all, thank you for having me. You're one of my very best friends in retina. We've kind of grown up together. We got a lot of parallels in our career, and it's a real pleasure to be on this journey with you. And we'll get into some more of that, as the night goes on. I am a native of Tampa Bay. I grew up in Tampa Bay. I went to the Florida public high school system. I was in Tampa for my bachelor's in medical degree, which I did in a 7-year combined degree program. And after fellowship, I then trained in Texas and Florida and decided to come home. I live in my hometown of St. Petersburg. I live on the opposite side of my hometown, so I can feel like I have progressed socially from my childhood. I married a girl who grew up in St. Petersburg. We were set up on a shidduch, which is Yiddish for a arrangement where we meet other Jews, and it was a beautiful shidduch. Everything has worked out. We have 2 lovely kids, Max and Miriam, Marbar and Max Bax. And I feel very fortunate and happy with all of that. And with my practice, I'm in a medium-sized retina practice. I know you know my practice well. There are 6 of us. Hopefully, there'll be a few more of us in the next couple of years. I've thoroughly enjoyed building the clinical science part of the practice, and I love everything about this field, what I do, where I get to come to work every day. I'm not sure if it chose me or if I chose it or if it was a little bit of both, but I'm a happy retina guy.
Well, they're lucky to have you, local boy growing up, getting trained and coming back home. So that is fantastic. So what got you interested in ophthalmology and retina, David?
That's a great question. My dad was an internist, and one of the reasons I did a 7-year BSMD program is I was well directed. I did not have a lot of choice in the option to become a physician, and I was okay with that, but I thought I would choose something very traditionally masculine, like a trauma surgeon career path or cardiothoracic career path or head and neck surgery. So I went to medical school. I was 20 when I started on the medical school part, so I did not get to go on the pub crawl for 21-year-olds and up. They would not sell me a t-shirt. I was 20 when I went to medical school with all these ideas of masculine grandeur. And then, I'm 22 in the clinicals, standing up in a trauma surgery operating room, weak in the knees, tired, thinking about how gross this is, really confused as to what I wanted to do. I did not know what I wanted to do then. I didn't know if I wanted to stay in medicine, thought about psychiatry. I thought about business and going into the business of medicine. I took the GMAT, theoretically going straight to get an MBA after med school. And then during my clinicals, that 3rd year after surgery, I met a patient who was suffering from a progressive form of multiple sclerosis. And before she was disabled, she was an ophthalmologist. And I got to know this patient throughout that rotation, and everything that she told me about ophthalmology was what I thought surgery would be like. It's elegant, it's clean, you get to sit down, which is a big deal. you use all these cool devices. You even get to use lasers sometimes. I thought all the surgeons use lasers. All they use is big knives. And it was a combination of her articulation and me being vulnerable probably that made me fall in love with the idea of ophthalmology. So the 4th year of medical school, I went basically to the ophthalmology department, and I've never left, essentially. I've been there ever since. And the second part of your question, why retina? Because when I went to ophthalmology, I was thinking orbit. I was still thinking big surgery. I was thinking, I'm going to be an orbital surgeon. I'm going to do big surgery. It's going to be elegant big surgery, but it's big. Anyway, orbit was gross. It was a lot of fishing around in the ice cream cone behind the ball of ice cream. It's dark and sticky in there, and you can't see what's in the ice cream cone, and sometimes you break it. And retina was beautiful. I loved what I saw when I could finally see the retina. You probably remember this, Arshad. You could finally get that 20 diopter lens to work. That darn thing doesn't work well when you're training. When you finally get it to work and you get the scleral depression and you find the break, you're like, this is amazing. Look how beautiful this is. And there was beautiful imaging. It was the birth of commercial OCT. It was a combination of beauty and elegance that I still enjoy. I still enjoy the beautiful things we see clinically and through retinal imaging and during retinal surgery. It's a beautiful thing to behold, and that's why retina.
No, that's a really great answer, and I agree with you. I think on a daily basis, we get humbled and we find things that we have not seen before, whether it's a patient with some tumor or, I just saw a lady the other day with endometrial tumor in her eye causing a serous detachment, and then she got treated and the detachment went away and her vision got much better, and she was very thankful to me for getting her vision better. And I said, I didn't do anything. I just diagnosed and I sent you to the radiation oncologist who fixed you. But yeah, she was so I agree with you. I think seeing things the way with the clarity and with imaging, with our exam, is just phenomenal. And every patient is so unique, and it's so exciting to go to clinic every day, as you said. So you already told us about your private practice and you went back home. Tell us about how many patients do you see in a normal clinic day, and how has COVID-19 pandemic affected your clinic? And then after that, we'll talk a little bit about how you're managing diabetic retinopathy.
Oh, great. So just like you, I do a lot of the work during the day for the clinical science program. It takes up a larger and larger proportion of my time. But probably my favorite thing to do moment to moment is actually to see the patients and take care of the patients. The clinical science is my favorite concept, but the patients are probably my favorite momentary interaction. And I still have a robust clinical practice like you and like a lot of our colleagues in clinical science. Excluding the clinical science patients, I'm probably down to, on a full day, probably down to 50-ish normal patients a day, 50 to 55. I used to do more, but I can't do all of the stuff with the science program and keep seeing, 55 or 60 or 65 patients a day. I like to see 50 a day. That makes me happy. It's been slower. It was last quarter, especially when we were at the peak of Florida's version of the pandemic, which was when there was a moratorium on elective procedures and things like that. We were probably down about 35 or 40% compared to our regular winter spring volume, which is a big reduction. Things are probably back to about 90% of where they would be. What's really interesting is this year was going to be a really busy year with meetings and presentations and some family trips, all of which are canceled. So some days like today, when we were supposed to be at the Retina Society meeting in New York, clinic was open, but it was only about 30 patients because we opened it 2 months ago or whatever. So it's really interesting time. But my happy place, barring all the COVID stuff, is probably about 50 normal patients a day for me at this point. Makes me happy.
No, I think that sounds like a good number, plus the clinical trial patients. And, you have to treat them like VIPs, spend more time. So I think I'm glad to see that you're not rushing through them, because I think that's why you're so successful in recruitment and retention for those trials. So tell me about your diabetic patients. And we are specifically just talking about diabetic retinopathy, not macular edema. Have you seen that during COVID-19 that you're seeing less diabetic retinopathy patients? and they're coming in too late and not coming in early enough. Have you noticed that in your practice?
Yeah, so diabetics, I think, are always the patients who come in a little too late and miss their appointments. It's been hard for me to parse out whether or not they are coming in even less during the pandemic. The seat of my pants sort of feel on that is that they are probably the ones who are not coming in. It might be because they're nervous about the pandemic. It might be because they've lost their jobs and lost their healthcare coverage. It might be because they're looking for an excuse to not go to the doctor
Right.
because they're apparently non-compliant, which is how they wound up with you and I. But I think there are more interruptions of care for the diabetics than the AMD patients or the RVO patients during the pandemic. And we do see some advanced disease, and we, even before the pandemic, and these are cases that have been discussed on podium, we see significant disease advancements in diabetes with interruptions in care, especially when we're leaning on our injectables so much for severe non-proliferative and proliferative disease.
So since you mentioned that, tell me, how are you managing your patients with severe NPDR and NPDR? Are you using anti-VEGF agents? Recent data from PANORAMA, has that changed your use? And of course, the data from RISE and RIDE that got approval for ranibizumab in the past. So specifically, just population without DME, when a patient walks in, how are you managing it, and what are you discussing with them?
Yeah, so I've believed the data since RISE and RIDE, and the data from PANORAMA, which kind of makes the population even cleaner. It excluded the patients with center involving visually significant DME, makes me believe in the data even more. So I'd say that I'm using pharmacotherapy for severe NPDR more than I used to, but it's still not a lot. It's still not a ton. Because the last thing I want to do is scare off a diabetic patient. I'd rather have the patient engage in their care and coming in than treating 100% of the severe NPDR patients with injections. I talk to 100% of them about it, and I offer 100% of them injections, and I push them if they have had problems with the contralateral eye, especially with the data that we've learned from PANORAMA and the Q16 week arm. It's not a lot of shots, and that's what I tell them. I say, I can protect your better eye without a lot of shots. Or if they're enthusiastic about the idea, I tell them I can protect both your eyes from advancing like your mother did, or your friend did, or your sister did, without a lot of shots. But I'd say that I'm probably still using pharmacotherapy in only 10 to 20% of my severe NPDR patients. Is that what you're doing? Are you doing a greater proportion, would you say?
No, I think I'm probably less, same or less, because, these are patients with good visual acuity. And I think people who understand the progression that, if you look at the PANORAMA data, the vision threatening complications and events, we have to explain it to patients, the vitreous hemorrhages, the DME that's going to take their vision away. I think some of them get it, and the more compliant ones will get it, and they come back, while the rest just want to watch because they have no symptoms and they're seeing 20/20. So I totally understand the patient perspective, but I think as physicians, our job is to offer them the treatment and then, help them make a decision that they're happy with. And I agree with you. I think if you offer it first time and just inject their eye, they may be shocked and they may not want to come back. And then, as you said, they may scare away. What about PDR patients? What is your management for patients with, let's say, early PDR? Are you using anti-VEGF plus laser? Are you doing just anti-VEGF? What are you doing?
Yeah, so PDR, I think that we're conditioned to treat that, even if the patient is asymptomatic. And a number of the patients who present to us with PDR at least have a vitreous hemorrhage. They have even a mild one. They have something some reason that they know something is wrong, but not all of them. Let's say the patient with mild PDR without any symptoms still gets treatment, I think, in 100% of retina clinics, or close to 100% of retina clinics. And I think that anti-angiogenics should have a role in everybody's PDR treatment protocol. For me, I've gone through phases. When we first learned about the data looking at PDR and intravitreal agents, I used them, even pre-Protocol S, I used them once or twice, then did a bunch of laser. Then Protocol S came along, and I used pharmacotherapy as a monotherapy. And then I had some of these vision-threatening complications and treatment interruptions, and now I've gone back to using pharmacotherapy in essentially 100% of my PDR patients, but combining it with pan-retinal laser. Is it effective pan-retinal laser? Is it necessary pan-retinal laser? Is it dense enough? Am I treating me? Am I treating the patient? Am I treating both of us? We're all trying to figure that out, I think. But I think that I'm treating the patient with enough pan-retinal laser with anti-angiogenic injections to affect disease regression, give them some permanence with the laser, and protect them from vision-threatening complications while they're getting their laser. And I usually do my laser for PDR patients, whether they're mild or severe PDR, over 3 sessions in combination with anti-angiogenic agents.
No, I think that's a very reasonable approach, David. So let's move on. Let's talk about your patients, and let's talk about, before we ask you some questions that all of the guests answer, tell us about what do you think will be the biggest game changer in management of patients with diabetes going forward? I know you're involved in a host of clinical trials, devices, delivery system, longer acting agents. What are you most excited about?
Oh man, that's a great question. Let me put it into 2 buckets. One bucket is things that are probably coming to market that are in late phase, and then things that we would love to see work that are kind of conceptual and early clinical or preclinical. So the things that are, the one thing that's coming to market that's really disruptive and we've got to wrap our heads around it and figure it out is port delivery. We have to figure out who it's for, if it's for you or I or our colleagues as surgeons. How do you employ that? That's the first thing that's truly different than the intravitreal injection we've been doing for over 15 years. Different is good. It makes us think. Is it going to revolutionize our treatment? Is it going to go into most of our patients? I doubt that, but I think that it is very important to engage with it in a practical and clinical sense so we can move forward. We talk about how exciting retina is, and we talk about how exciting pipeline is in diabetes and macular degeneration, but we haven't seen a lot actually change. We're like, oh, look how exciting our pipeline is, look at all this stuff, and nothing has really changed in 15 years. Now we have something that has the potential, should it merit approval in diabetic macular edema or NPDR, should it merit approval, it's going to change the game more than another injection. Of course, we have a second MOA with anti-Ang2, which is right on the heels of port delivery, and that's also exciting. It's still another injection. I think, frankly, that has a better chance of being a blockbuster product than PDS. That's the faricimab injection, but it's still another injection. Moving a little bit further to the second line of stuff I'd love to see work. I would love to see an intravitreal agent with a truly different technology. And one could say that the long-acting polymer technologies like the Kodiak product would be that exciting agent. But I'd like to reach even deeper and say that the exciting agent would be gene therapy, which I know you've been very involved with. Something that is truly altering the tissue. And gene therapy means a lot of different things, as you know. You can alter the tissue to produce a drug, you can alter the tissue to fix a genetic defect, and there are a lot of delivery systems, all probably beyond the scope of this talk. But I am most excited in the more distant future about the potential of gene therapy to unlock a whole new way of treating disease. In the near term, I'm excited to see what we do with PDS.
No, I think those are all great options. I tell you, you and I are involved with all of these trials or most of these trials. And I mean, this is so exciting to have so many options that are showing great results, whether it's in early stage like gene therapy, whether it's in late stage like PDS, faricimab. So I think you're right. I think we are going to be managing patients differently with diabetic retinopathy, 5 or 10 years down the road. So let's move on to some personal questions here, David, that we ask all of our guests. What profession other than being an ophthalmologist and a retina specialist would you like to attempt, and what profession would you be horrible at? And I can give you the first answer. I think being a member of Mother Pucker's band, I think you were probably going to say being a guitarist or a lead vocalist. Is that correct?
No, that's one that I think that would still have to be a hobby, because I know I would fail at that. But
I think you're pretty good, man. I think you can make a career out of it.
I will tell you what I wanted to do, and time proved to me that I would fail at it. I wanted to be an automotive product planner. I've always loved cars, and I wanted to plan what cars people would buy. So here's a true story. 1991, the Ford Explorer comes out. The Ford Explorer, as everybody knows now, is a sport utility vehicle. It's a four-door body plopped on a little pickup chassis back in 1991, a Ranger chassis. Same year, 1991, Mitsubishi releases the 3000 GT VR4, which is a twin turbocharged, 300 horsepower, 6-speed, four-wheel drive, four-wheel steering supercar. So here I am, 1991, 15-year-old me, thinking I want to be an automotive product planner. Who's going to buy that lame Ford Explorer? Everyone's going to buy the Mitsubishi 3000 GT VR4 because it's a Ferrari that anyone can afford. It was outperforming the 1991 Ferrari 348. And look what happened. 3000 GT VR4 died quickly and is now forgotten, and everyone has an Explorer. So I would have been a horrible automotive product planner. Even worse, possibly, than a guitarist for the Mother Puckers.
So what about something you think would be good at if you didn't do retina as your profession?
Something I'd be good, something I think I'd be good at that I would probably enjoy. I really love my little kids more than I thought I would, frankly. I think I could be a teacher for little kids.
Nice.
I think that little kid, like under 10, I think. Maybe that's because it's the only experience I have with kids, like 3 and 8. But I really think that maybe I love going into my son's classroom when I could last year, pre-COVID. I love going in there and reading books. I love going in there and bringing them donut holes, which is super naughty, evidently, in 2020 or 2019, because donut holes are people. But I think I would be really good with a bunch of little kids. I think that would be something I'd be good at. I don't think that I want to do that, but maybe I'll do more.
I think that's a very tough profession. I have the most respect for teachers. So even considering that, I have a lot of respect for you, man. I don't think I would be able to make that for sure. So let's talk about travel. When the world opens up again, where are you going to be right away? What's the first place you're going to be at?
Travel. I do miss traveling some. The first place I'm going to be is at a Ruth's Chris with you, having a baked potato and a sizzly steak and a CME talk. That's where I'm going to be.
Come on, I'm talking about travel outside work.
Travel outside. I'm going to be, every summer I've taken my family to the beach, to the Cayman Islands specifically, and that's the trip that I miss the most. I would like to we're currently hoping to get to the Bahamas for Christmas, over Christmas. We like to leave town for Christmas. I don't know if that'll happen, but I'd like to take my family to a beachy place that's a nonstop short flight from Tampa. That's the place that I'd like to be. How about you? Where will you be when
you know where it is, man? Turks and Caicos. Go sit at the beach and enjoy. And Elmo is there for the kids, and it's just our destination spot. And it's really far for us.
Yeah, you don't have
getting to it, but once you get there, you forget all about about it, and then.
Do you have a nonstop to Turks and Caicos for the 6 Kananis, or no?
No, we have to stop in Miami.
I love it. Yeah.
Yeah, but once you get there, it's like paradise, and you forget about it. So last 2 questions before we close the program, David. We ask everybody, what is your favorite retina-related word?
My favorite retina-related word is druplet. I think it's the cutest retina word. A druplet, for those who may not know it, is a drusen less than 63 microns in size, not associated with pigmentary changes. And I think if I had a 3rd child, he or she would be druplet Aisha.
That's a great word, very, very unique and very rarely used. So that's great that
I don't think
that.
I don't think I've ever used it clinically. I think I only discovered it because I was doing a CME talk on dry AMD.
No, that's fantastic. And then the last question everybody gets is, you're already pretty successful. You have created a really good clinical science program. You're on the podiums, you're on papers. You really have done well in your career so far. So when you retire, what do you hope the patients and colleagues like me say about you?
That's a good question. I think I'd like them to say, I don't know what happened. He was standing right over there a second ago. No, I'm kidding. I may die in the office, but perhaps not. Aside from that, if I don't die in the office, I'd like people to say that I worked hard. I was a hard worker, and that I supported people. I supported my friends. I supported my junior retina specialist. That I built things up. Yeah, I'd like to be remembered as someone who worked hard and built up institutions, people, science, all of that. That's it. And hopefully that I didn't die exactly in clinic.
No, I think those are really great. And I think I would already say that about you, David, that you're a good colleague. You communicate well. I enjoy working with you. So really, I want to close the program. Thanks for joining us on this episode of Inside the Doctor's Studio Retina, where we talked with Dr. Eichenbaum about diabetic retinopathy, some cars, and all the other things. So David, thank you for joining us today. It was a pleasure.
It's a pleasure. It's always fun to talk with you. I miss seeing you. All the best to you and your large family. I hope things are good.
Thank you, David.
We have our third guest, Dr. Dilshir Doot. Welcome, Dilshir.
Hey, Arshad, thanks for having me today.
It's great to have you. So tell us about yourself.
Well, I practice with California Retina Consultants. We're based out of Santa Barbara, California. We're a group of 10 going on 11 physicians in a private practice setting, heavily involved in research. So we're kind of an academic private center of sorts. And we cover the central portion of California.
And tell us about yourself. Where are you from? What got you into ophthalmology and retina?
Yeah, I think it was a fortuitous course. I was born in England, actually, and grew up in England until age 12, and then into California. I'm by ethnicity, I'm Indian, and so for me in medical school, I always knew that I wanted to do something that was procedure based. I liked using my hands. I liked doing surgery, and I just came upon ophthalmology by chance on a consultation during an internal medicine rotation. And started to think about it more and started to get involved in the research, and one thing led to another. And retina was just a natural choice. I think retina really, we have the most dynamic specialty within ophthalmology with all the research that's going on, all the cutting edge treatments. It's really a great opportunity to be part of this field.
So tell us who really guided your interest in retina. Who are your mentors that you really have helped you pursue this career and who always continue to help you?
Sure. Yeah. So I went to residency at Casey at OHSU, and my mentor there was Tim Stout, who's now at Baylor as the chair. I worked in Tim's lab, and so Tim was probably very instrumental early on. And then I felt very fortunate to match at the Cleveland Clinic, where all those guys have become great friends and mentors over the years now. And so Peter Kaiser, Rishi Singh, Dan Martin, of course, Sunil, the whole crew, have all been very instrumental in the growth development for me.
No, I think that's a great group, I tell you. Smart guys and very, very good friends of mine too. So tell us about how are you treating? Let's move on to some diabetic retinopathy treatment and evaluation, because that's the focus of this episode. So tell me, how are you treating your patients with diabetic retinopathy? I know you have published several papers about using anti-VEGF and some analysis from Vivid and Vista and other studies. So tell us about that, how you're treating and diagnosing your patients with diabetic retinopathy and how COVID has impacted that.
Sure. I mean, I think that in general, this population is a tough population. Even pre-COVID, adherence for this population is difficult. They have so many things going on with the rest of their body, kidneys, nerves, etc. And so this, as you know, is a population that often doesn't follow up on the schedule that they should. for me, I think the biggest way to treat them is to educate them. And so a big part of the education, I think, is their imaging. And so I'm a big imager. I love wide field imaging. Wide field fluorescein angiography has become instrumental. At this point, when I started practice, gosh, 8-9 years ago, we were Topcon based, 30-degree field cameras, but now every single one of our satellites pretty much now has an Optos wide field image, and I find that that's really important to really understanding where this patient stands in their disease process. I think just the clinical exam or just the fundus photos are sometimes underwhelming. Then you can get a fluorescein angiogram and you're just very impressed with what's going on. Part of your question there was how I treat these patients with diabetic retinopathy. It's a no-brainer when they have DME that's comorbid, because these patients are motivated to have better vision themselves, right? But the DR patient that has good vision, that patient in both eyes, that's the harder patient. And so that one, you really have to introduce the concept of treatment early, time after time, and get them comfortable with the potential of having treatments, especially injections, for example. But I am treating more, especially the level 47-53 patients, with anti-VEGF. I think the PANORAMA data was very helpful to us in trying to find a reasonable interval where these patients are not overburdened. And so, I typically follow kind of a PANORAMA scheme in my treatment regimen, but I am starting to introduce the concept of treatment and starting to treat these patients more and more.
And what % of your patients actually, let's say with moderate or severe NPDR, decide to have treatment? And do you give them a chance to digest everything, or you treat them on the spot like we do for DME and AMD?
I think I give them a chance to digest. I mean, if they're bilateral, good vision, but bilateral 47-53ers, we get the angiogram. I show them their photos. I try to make it hit home that this is not just because a lot of these patients are coming in because they were told to come in, right? And they're not necessarily having a problem. And so, that's a harder population, but I introduced it slowly, and it's hard to treat them that same day. If a patient has had, a vision-threatening complication in one eye, then I think it's a lot easier to potentially treat their fellow eye in that setting. And so that patient, is probably going to be fast routed to treatment or fast tracked to treatment over a patient with good vision in both eyes.
No, I agree with you. I think when they know what's going to happen with this eye, they had proliferative diabetic retinopathy or with vitreous hemorrhage or bad DME, I think the threshold for treatment, they're much more accepting versus 20/20 vision in both eyes. They don't see a problem. We see a problem. So I think that's a very complicated situation sometimes, but I agree with you. I think I don't treat them on the spot, and I offer it to treatment. A large number of patients don't want treatment. They want observation, but PANORAMA really helped us in that sense that, for a pure patient with 47-53, they don't need too many injections, once you control the disease. I mean, anywhere from 8 to 16 weeks. And I think that's much more reasonable than treating them monthly. So how has pandemic affect your practice, and how many patients do you see, by the way? And has COVID-19 done anything to your practice, and especially to your diabetic patients?
Yeah, most definitely. I think COVID hit us hard in March, April time. Our volumes dropped to about 50%. Typically my day varies depending on which clinic I'm at, but I can see between 50 and 80 patients checked out at various clinics. And, these volumes went down dramatically, about 50%. A lot of our satellites, we consolidated days. For example, if I was someplace remote, that's, Tuesday, Thursday, I just made it, just for Thursday only, and we cut the other clinics. We saw these volumes start to pick back up late April, May. And by now, in June, July, we were almost at full capacity again. I would say now here we are in August, about to enter September, and we're back at full capacity for the most part. The diabetic patients, I don't have a great sense of, if they were any worse off. I think that they probably were more apt to miss appointments than, say, their AMD counterparts, just because the AMD patients really notice, the drop in vision more acutely. And so we did have some diabetics that maybe went a couple months even over their scheduled return. And so, and then they had recurrence of edema, for example, in the DME patients, and the DR patients. Some of those patients did fine. It's really case by case. But for the most part, we're seeing them now follow up again. We send them reminders, we send them letters when they miss, and so we try to get them back in. And fortunately, with diabetes, the entire system is getting better at emphasizing the need for eye appointments. And so if you miss someone, it's been several months, a lot of times they'll get hit by their primary care to come back in as well. So that's, I think as a medical system, we're doing better at getting our diabetics into their offices for eye exams.
So for proliferative diabetic retinopathy patients, tell us how you treat them. And because of COVID, are you doing more laser because there is obviously difficulty coming back in, or do you feel like your patients are compliant enough to come back for continuous anti-VEGF treatment?
Yeah, I've always done a combination of laser and anti-VEGF. Like, I recognize the data from the various studies like Protocol S, but in general, for me, laser is still a mainstay in PDR patients. Though my lasers changed a fair amount, I do more anterior laser. I'll leave close to the arcades open, and I'll supplement with anti-VEGF on kind of a quarterly basis, or every 4-month basis even. These patients we did probably have, and we'd love to see in a formal fashion my own data to see how many diabetics did show up, but during that period. But I feel that some of these patients have breakthrough vitreous hemorrhage, some of them don't. The ones that do definitely come back. The ones that don't, you can see be lost to follow-up. But for the most part, I think that we're seeing them coming back now. Our volumes have picked up, and we're definitely seeing them get back into the routine and schedule of things.
So is your clinic much slower now in terms of efficiency because of the precautions for COVID, or do you have more staff or more rooms? How are you working around that? Because, going back to the same volume with the extensive cleaning, all these other precautions that we are taking has really taken an impact on my efficiency, at least.
Yeah, no, I would agree with you. I think early on, especially, the technicians are much slower at the various precautions we take, the universal precautions, and sanitizing the rooms. But it seems like they've gotten faster at it. They're in there, and kudos to our staff is outstanding. They get through. We can get through a lot of patients, and it seems like, it's cliche to say it's a new normal, but that's really how it is. Like, they're fast and efficient, and they're doing everything the right way. Everybody's wearing masks, and the staff has been very good about that. And so I think that our efficiency is a little bit less than what it was pre-COVID, but since as we've gotten used to things and the new normal, the efficiency definitely picked back up.
No, I agree. I think initially it was very difficult, and now we have a system going to see how to take care of that. So talking back about your diabetic patients, so let's say you start a treatment for severe NPDR, how do you keep them compliant? I mean, how do you make sure that, because they're not going to see an improvement in their vision, so how do you make sure that they come back for their follow-ups and their injections every 8 or 12 or 16 weeks?
Yeah, I think it's really is a the buy-in there is it can be difficult. We mentioned here that if the patient doesn't perceive decreased vision, keeping them bought in is difficult. I think the only way, in my mind, to do it is by education, right? And so we at every visit we have the imaging up, so we have the initial fluorescein. I do fluorescein every year, typically for my diabetics, like the level 47-53 population. And, I try to show them the findings repetitively to show them that, we're trying to prevent these, A, B, and C vision-threatening complications. And I emphasize what those are. And in a short, that visit doesn't have to be very long. And, a couple minutes of conversation, you can remind this patient why they're going through this injection today, and try to keep them bought in. And so I think really it's education that I see as the best way to keep them bought into the whole process. I have a friend who actually makes her patients sign a contract, and the contract says if they miss more than 3 appointments, they actually get fired from her clinic.
Wow.
And that's fascinating to me that she's able to do that. I'm not so harsh, but for me, it's just an education process, and it works. It seems to work, but again, we don't honestly probably know about the, the segment that falls off and then, returns back, because the best we can do is send these letters and hope that they'll eventually come back.
No, I agree. I think compliance is an issue, and it's always gonna be an issue. And I think keeping a close eye. But I don't make him sign a contract. That's like, I don't want to threaten them. But I understand why your friend is doing that, because you really want to make your treatment based on their compliance. And especially with PDR, if somebody wants injections, and I have some patients who just want to do anti-VEGF, and if they fall off, and don't come back for 6 months or 12 months, as you said, they may end up with a tractional detachment and vision loss. So I see why that's been implemented, but yeah, I don't do that either. So let's talk more about your patients. What's the best thing you can hear from your diabetic patient, and what is your least favorite thing to hear from them? For me, it's like, you do a great job with an injection and they say, oh, it hurt, or like they don't want to come back, or especially young males passing out, because they have to get a needle. And for me, the rewarding thing is, you have a one eye patient with a vitreous hemorrhage or tractional detachment, you fix it, they can see again and their life changes, but that's just me. So tell me, what are your thoughts on that?
Yeah, no, I agree with all your scenarios too. I mean, I think the least rewarding is when you've injected someone, maybe they're on their 4th injection, and that 3rd one, doctor, that one really hurt a lot, and it's like, wasn't really in my mind, it's not the injection that hurt a lot. It's I'm sorry, maybe the betadine stuck around, or maybe you got a little scratch and abrasion. But you did something different. I do a lot of these every year. I feel like it's pretty much exactly the same, because they're not hard to do. So so that's probably my least favorite thing is dealing with that sometimes. Or actually even sometimes dealing with the question of how many more. I mean,
Yeah.
Patients become exhausted with the injections, and that's hard too. And it's hard to tell patients. I try to give them a nugget. I try to tell them about all these cool, future treatments that are down the pipeline here, and so they have some hope, to something that may last a bit longer and give them reduce their burden. The most rewarding things that patients can say really relate to vision, and how you change their life. I mean, there are patients that, like you say, especially these monocular ones where, you've sat and waited on this traction that's evolving, and the fovea is not quite involved. And then finally you got to go in, and this is their only eye, and, the pressure's on you, and so, but when you're able to stabilize an eye like that, that is very rewarding. And you see these people have, the quality of life and is so much improved by what we do. That's very rewarding. And the same thing goes for just medical treatments. Like when we're doing medical treatments on patients with DME, for example, or in-office vitreous hemorrhage, and we see that we're able to improve their quality of life. That's very rewarding, especially when you know that you've made a beneficial impact on their quality of life.
No, it's clearly, what we do is very rewarding in most cases, where we can really help patients gain their independence and have a great quality of life. You see these patients coming in, only one eye can't see, they're bumping into walls and they need help. And then once you do something and they can see again, they can go back to, driving and working, and really very, very rewarding for sure. So tell me, what upcoming treatments are you excited about, and what is the game changer in your opinion in the future in terms of current pipeline? You got, you and your group are involved heavily in clinical trials, and I am too. And really it's great time for retina. We have so many potential treatment options that seem to be working well in early stages. But if you had to pick one game changer, what do you think that's going to be?
I think the one that is probably the biggest game changer that I see is gene therapy. I mean, to have, ocular biofactor of sorts that produces an anti-VEGF like molecule. I mean, that's still early compared to some of the other meds, but I mean, that if that pans out, we can sort out the inflammation there. I think that's going to be huge, and so for me, I'm super excited about the concept of gene therapy. And I think that, if we could foresee into the future, 10 years from now, we'll laugh about the days that we did injections every month. So I think it's going to be that the impact there has a great potential.
No, I agree with you. I think there's so much happening, and clearly gene therapy, if you can get close to one and done, I think it really has the potential, but obviously we need long-term safety and efficacy. You know, the first DME trial in gene therapy just started with ADVM-022, the Infinity trial, and with RGX-314, you're gonna have some DR trials starting too. So yeah, I'm hoping that, you know, I think the best way to treat the diabetic population that tend to be non-compliant and can come in and busy with their work or whatnot, I think it's sustained delivery. And whether it's, you know, PDS or gene therapy, I think continuous delivery probably is the way to control this disease. But because you know that injections work, but clearly we are still losing a lot of vision in these patients, partly because of the non-compliance and the treatment.
For sure.
I'm on that with you for sure. So now tell me some personal questions. So if you were not an ophthalmologist, what profession you would have been good at, and then what profession you would have been terrible at?
I think that, you know, the thing that I like to do on the side is a little bit, I'm like a mini developer. So I like to build, you know, construction and do things like that, you know, whether it's like a house for myself or whether it's a multi-family unit. So things like that excite me, like taking a piece of bare dirt and raising up a building there, you know, and those kinds of things I really get excited about. So that's probably what I would do. It's probably what I'll do after I retire. I just find that to be fun, you know. And then I think what I would be terrible at was probably like a pediatrician. You know, my patience is not great. So it's you know, having the patients to deal with you know, the pediatric population. You know, God bless all of our pediatric ophthalmologists. You know, it wouldn't be a job that I would be able to do, to be honest. And so that's probably a job that I could see myself not excelling at.
Yeah, I mean, dealing with kids in clinic, especially doing pediatric ophthalmology, I think it's so difficult just to get the kid listen to you and then doing an exam. I agree with you. I think it's not an easy job, and I have a lot of respect for our pediatric ophthalmology colleagues, because not only they're able to do their job well, but also, you know, help these kids not go blind. And, you know, especially measuring strabismus.
Yeah.
They'll walk in with a prism and say, "This is it." And I'm like, I don't know what to do with it. But construction sounds like fun. You know, I'm like you. I like to build things. I just make other people do it.
There you go.
No, I mean, construction is great. I'm more into gardening and, you know, traveling. Those are my favorite things to do. Okay, so tell me about your travel. I know you like to travel a lot, and, you know, it's been shut down for all of us. And once we are COVID-free in terms of a vaccine or a treatment, what will be the first place you're going to go travel to?
Yeah, this was supposed to be a big year for travel. I mean, for both of us, I'm sure. We had, you know, usually I pair all my travel these days with meetings. You know, the one that I'd love to go to now was where it was going to be the World Ophthalmology Congress in South Africa. Yep. I had that all booked up. It had the safari and everything. It was going to be an insane time, but, you know, it's unfortunate that one got canceled. That's probably the one I'm looking most forward to doing again, especially because they've kept my deposit. And so I'm looking forward to doing that one. But there's so much travel, unfortunately, that, you know, I hope that the world will be a place that we can again access, you know, almost anywhere in the world with ease. You know, hopefully we'll get there at some point.
Yeah, hoping soon, man. Yeah, we all need to see each other and you know, discuss a lot of things and travel. Clearly, I really miss the meetings. You know, the interaction in the hallways at the meetings and getting to see our colleagues and having, you know, discussions about how we can help our patients and get and what's going on in our social lives and our practices. You know, that's something I clearly miss for sure. And then so South Africa sounds really good to me, because you know, that's one location I want to go to, and I promised my wife a long time ago that I'm going to take her to a safari. That hasn't happened, but eventually, we'll get there. So before we wrap up, I know time is coming up here. So everybody who's a guest on this show has to come up with their favorite retina related word. So what is yours, Dilshir?
I think my favorite word, you know, I like to eat, Arshad. And so anything that has anything to do with food and retina is going to be my word. And so that word is vitiliform. It's an egg yolk like. I like that. Vitiliform is a cool word. Hopefully no one's picked that one before, but that's going to be my word.
No, that's good. You're the first one to have it. We have had some great ones, I tell you. So for the audience, they will know by now what other people have picked. But I like it, Vitelliform. It sounds good, it looks good, and it reminds me of, you know, food. That's fantastic. And then the last question everybody has to answer, you know, you're on a great career path right now. Your group is great. You work up with a bunch of great physicians. You guys are involved in research. Have really done a nice job with your impact, you know, in the literature as well as podium. So when you retire following your successful career, what do you hope that patients and colleagues will say about you?
I hope that people will say that I was, you know, a good doctor, and my patients will say I put them first, and, you know, the decisions I made were in their best interest. And I hope that my colleagues will say they had a lot of fun with me, you know, along the way. You know, we all work hard, and, you know, and we go to these meetings, we play hard. And I hope that, you know, first and foremost, that they consider me to being a good person and good doctor, but, you know, also then a fun colleague.
No, I mean, you are a lot of fun for sure, Dilshir. I think we're going to say that even now. So thank you again for coming on this show. We appreciate it. And I hope to see you soon at a meeting.
Hey, thanks, Arshad. See you soon.
See ya.